Inversion ankle sprain physical therapy. The ankle, or talocrural, joint is an articulation of three bones, the talus, the fibula, and the tibia. 1. Three ligaments provide lateral support to the ankle. The anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. 1. The deltoid ligament, which consists of the anterior and posterior tibiotalar ligaments, the tibiocalcaneal ligament, and the tibionavicular ligaments, provides medial support to the ankle. 1. Peroneus longus, Peroneus brevis, and Peroneus tertius evert, and provide dynamic stability to the ankle. 1. Ankle sprains. Approximately 30% of injuries suffered by collegiate and high school athletes are ankle sprains. 1. In the U.S., ankle sprains occur with an estimated incidence of 2.15 sprains per 1,000 people per year. 2. The anterior talofibular ligament and the calcaneofibular ligament are the first and second most commonly sprained ligaments, respectively. 1. These ligaments are often sprained simultaneously via forced plantarflexion and inversion. Mechanism. 1. While less common than an inversion mechanism of injury, a forced eversion mechanism of injury may result in a deltoid ligament sprain. 1. Classification of ankle sprains. A sprain occurs when a ligament is stretched or torn. 3. Sprains are classified by grades I, least severe, to 3, most severe. 1. Examination of ankle sprains. A physical therapy examination of a sprained ankle should subjectively include questions regarding the onset of symptoms, the distribution of symptoms, aggravating and easing postures, mechanism of injury, prior treatments, and prior history of ankle pain. 4. Objectively, a clinician may choose to examine posture, single leg balance, gait, range of motion, joint mobility, muscle strength, and special tests when appropriate, i.e. figure of 8 test, anterior drawer, inversion stress test, Taylor tilt, eversion stress test, external rotation stress test, squeeze test, cotton test, fibular translation test. 4. 5. Treatment of ankle sprains. The healing process consists of 3 phases: acute, subacute, and maturation. 1. Depending on the severity of the ankle sprain, the acute phase will last 3 to 5 days. 1. During the acute phase, the patient should use cryotherapy, ice, to reduce pain and swelling. 2. Most studies recommend icing for 20 minutes every 2 hours. However, some research shows that an intermittent protocol of 10 minutes icing, 10 minutes off, 10 minutes icing every 2 hours results in greater short-term pain relief. 2. Patients should start bearing weight and exercise as soon as the pain allows. 2. During the subacute phase, which begins around 3 days after the original injury and lasts up to 6 weeks, tissue repair begins and collagen fibers start forming scar tissue on the injured ligament. 1. Gentle stress to the repairing tissue is necessary to ensure that the collagen fibers are aligning and developing properly. 1. The maturation phase may start as early as 1 week post-injury, grade I sprains, or as late as 3 weeks post-injury, grade 3 sprains. 1. During the maturation phase, it is important to continue stressing the repairing ligaments to ensure that the collagen scar tissue fibers align and develop appropriately. 1. While the maturation phase may last up to a year, return to normal activities may occur as early as 1 to 2 weeks post-injury, grade I sprains, or as late as 12 to 16 weeks post-injury, grade 3 sprains. 1. Physical therapy and ankle sprains, what the evidence shows. Earlier Cochrane reviews, 2011 and 2005, have shown that therapeutic ultrasound and hyperbaric oxygen are not effective treatments for acute ankle sprains. 2. Evidence shows that initiating range of motion exercises and mobilizing the ankle joint within 1 week post-injury results in better outcomes. Return to work or sport. 2. Incorporating strengthening and proprioceptive training into the rehabilitation process has been shown to not only reduce subsequent ankle injuries, but also reduce future hamstring, knee, and other lower extremity injuries. 2. A systematic review of 8 studies published in 2014 demonstrated that joint mobilization and manipulation techniques improve pain and range of motion in patients suffering from acute ankle sprains and improve function in patients suffering from subacute chronic ankle sprains. 6. A study published by Cleland et al. in 2013 compared outcomes between a group receiving manual therapy in addition to an exercise program to a group completing only a home exercise program. 4. Manual therapy techniques utilized included proximal tibiofibular joint thrust manipulations, distal tibiofibular joint mobilizations, talocrural manipulations, talocrural mobilizations, and subtalar joint mobilizations. 4. Both groups completed the same exercise program, consisting of stretching, strengthening, balance, and dynamic activities. 4. Researchers concluded that in this study, combining manual therapy with exercise resulted in greater improvements in short-term and long-term pain and function than exercise alone. 4. Having had a previous ankle sprain is the greatest risk factor for having a future ankle sprain. 2. Therefore, proper treatment and rehabilitation is of utmost importance when treating an ankle sprain to prevent a future reoccurrence.